Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back, listener, to the Rural American Surgeon Podcast. I'm your host, Dr. Randy Lehman, and I have with me today Dr. Dan Margo. He's practicing all the way up just at the tip of America in International Falls and other places in Wisconsin, and it is my pleasure and honor to have you on the show today, Dr. Margo.
Hey, thanks, Randy. It's great to be here, and it's good to see you again.
Yep. And we've gotten to know each other through our interactions at the Northern Plains Rural Surgical Society, now the North American Rural Surgical Society. And my understanding is that in 2015, it was the Northern Plains Vascular Surgery Society. You were heavily involved in the decision to not disband it, but change it to a rural surgery program, basically. Does that sound right?
That's exactly right. I was actually the president of the Vascular Surgical Society, but lived in a rural community. And there were a bunch of us in rural communities that loved to get together to talk about vascular surgery. But as we did less and less vascular surgery in the rural community, we knew it was time for a change. So we just redefined the society and we focused on rural surgery in the general sense. And we've been growing ever since.
Yep. So membership-wise, where was it at in 2015 and how's it grown now?
Membership-wise, the Vascular Society probably fluctuated between 20 to 30, maybe up to 40 members speckled across the United States, but the attendance at the meeting might be 20 to 30 surgeons, but all of a sudden the meetings were down to 8 or 10 surgeons, and we could sense that it was time for a change.
How many members do we have now?
I'm not sure of the member number, but I know that our meeting last January, I think there were 70 of us in the room, at least,
Yep.
Randy? So, definitely on the growth curve, and people seem excited.
Yeah, I'm happy to be part of it. It was a great, it's always like very relevant. Every conversation, every session, it's all super relevant to my daily practice. So maybe give us a little more introduction of you, your training, your background, where you've practiced, what kind of practice you've had, and then what are you doing now? What do you plan to do in the future?
Got it. Well, thanks, Randy. Yeah, Dan Margo went to medical school in Minnesota. I grew up in Minnesota, went to medical school in Minnesota, University of Minnesota, and then moved on to a residency in North Dakota, which is probably where I started to pick up an interest or at least an understanding of what rural surgery meant all about, having the privilege of doing a residency in a more rural state. But after that, it just wasn't enough. So I went off and did a vascular surgical fellowship. But even though I was a vascular surgeon, I wanted to live in a small town. So my goal was to bring these vascular surgical services into my small community. And for 10, 15 years, we did that. We were doing some significant vascular procedures in our community, but we didn't have the official vascular lab. For example, we weren't able to do an endoluminal aneurysm repair. And as our world changed, it was time to just let that go. So I have to tell you, I still to this day miss the vascular procedures, but it was just something I had to do if I wanted to maintain my marriage, my life, and my home in the small community. So we knew we wanted to live here. We live in Grand Rapids, Minnesota. We're happy to be here. And we weren't going to move chasing a career in vascular surgery. So we did a pivot. And so far, no regrets.
It's funny because there's an element of me wanting to be a surgeon, but also wanting to live in a small town.
Correct.
And so when I came here, there's a couple surgeons that are coming up and down the interstate doing very minimal procedures in my hometown, doing clinic, taking a lot of things out of the county. And I just looked at it and said, it doesn't have to be this way. And I'm only going to operate here. So that's going to push it, by default, it's going to push it into more services offered locally close to home. And that's what you did with vascular surgery, but then times sort of changed. I'm not sure. I hope it doesn't change for general surgery. I don't think it necessarily has to, because it's not quite as resource intensive necessarily as vascular. And the general surgeon is still the person that basically every hospital needs. Would you agree with that, or have any thoughts?
Absolutely. I think the general surgeon can be the lifeblood of the very small hospitals. And that's really where my practice has gone. I think you're probably working to really expand the services available at your home hospital. You're committed to that place, and you're going to do everything you can very safely and very well for your community members, your friends and neighbors. My model's a little bit different. I'm traveling. I'm the guy on the highway now, heading to even smaller communities than the one I live in, trying to help them stay alive and doing the most basic procedures. Well, some would say they're maybe not so basic, but things that can be done safely and well in these very small hospitals. That's my goal. We bring that service to the small community so the people from that town don't have to travel for certain things.
Yep. So tell me more about the procedures that you're mostly finding yourself doing these days.
Yeah, well, I have in the rural surgical business, at least one of the models is to have a short trap line. So there are probably 3 communities away from my hometown where I do travel every month. Big Fork, Minnesota, International Falls, Minnesota, and up to Baudette, Minnesota, all in northern Minnesota, all small communities that don't have a surgeon living in the town. And really, as much as I love replacing someone's aorta and doing vascular surgery, I'm not doing that anymore, and especially not in these small communities. So to your question, Randy, it's really a lot of endoscopy. I mean, almost to a fault. The service that we can really bring to these small towns is endoscopy. I do a whole bunch of colonoscopy and upper endoscopy. And then on the surgical side, laparoscopic cholecystectomy, hernia repairs of every flavor, skin cancers, skin lesions, soft tissue lesions, carpal tunnel release, those kind of things. I feel that we can bring to these very small hospitals and do them very well and very safely for the community members.
Let me say a few things. You say yes or no. Vasectomy?
Yes. Yeah.
Ganglion cyst?
Yes. We do have some orthopedic surgeons that also travel to these same towns. But if the right ganglion cyst comes up, we'd certainly take care of that. Ovarian
torsion?
If it came up, we would have the equipment to solve that. I haven't seen that for a while. And as a more of a traveling surgeon, it would have to come in on just the right day.
How about bilateral laparoscopic salpingectomy for sterilization?
Yeah, not doing that. We do have a GYN that also travels, and he is doing that. Now, back through the years, I have done that in some of these small communities, but not currently. It's not as big a part of my practice right now.
Any vascular going on, like any AV fistulas, varicose veins, ports, lines, anything like that, Hickman's?
Okay. I would say the varicose veins, something I did much, much more of in the past, and being more of a traveling surgeon now, less, but I would take care of varicose veins in the proper setting. AV fistulas, dialysis access, not really, again, because it seems like those things don't come in when I'm traveling. But then fast forward to your other access procedures like the Hickman placement, portocatheter placement, we're certainly doing those. And that's a great thing. For example, with colonoscopy, we might find the colon cancer. We take care of that. The patient meets their oncologist. They've got a future with some chemotherapy, and they'll want and love when they can have that port placed right at home. So we do those kind of things.
Okay, so that brings me to the last two that I was going to say. I was going to say hiatal hernia and colectomy.
Yeah, and so really it depends on which town we're talking about. But no, on the hiatal hernia. I have a long history of fundoplications in my past as well, but these smaller communities that I travel to, I let that go. We're not doing the hiatal hernia surgeries. If I had a surgeon partner in those communities that would be around to help take care of them, we could certainly think about that. And colectomy, not currently. And part of the reason for that is when I go to these communities, the schedule's full. And if I'm coming once or twice a month, the schedule is elective procedures and it's full for the next 2-3 months, let's say.
Mm-hmm.
So a lot of times the best service for that patient is to travel, and I'll set them up with one of my colleagues at my home community or one of the surrounding communities that they're comfortable traveling to, and they'll have their elective colon surgery there.
Yeah, great. So how does it go when you're not in town, and how often are you in these places?
Well, let's pick international.
For what period of time too?
Yeah, great. International Falls, for example, is probably my home hospital now. It's where I spend most of my time. And I'll travel to International Falls twice a month. But when I go for 3 days each time. So my commitment to International Falls right now is 6 days. When I'm there for 3 days at a time. If it's midnight and appendicitis comes in, we're going to take care of it when I'm there. If that appendicitis comes in the next week and there's no one there, that same patient has to get in an ambulance and travel all the way to Duluth, Minnesota to be cared for. So that's, I think, part of the reason that we have full schedules when I'm there, but also why there's just no room to add something elective. If we do a procedure that requires a short hospitalization and it just happens to be on my last day, we have a very good relationship with the hospitalist team, and typically they're very comfortable taking care of those things overnight until we get the patient discharged.
Do you ever shut your cell phone off?
I don't, but it hasn't been abused. It seems like we have a pretty good balance. People don't tend to overuse that or overcall, and I tend to leave it on all the time. That's an interesting question, Randy.
So basically, if somebody came in 10 days later with a potential surgical complication, would you be contacted about it?
Oh, I would hope to be contacted. I may not be able to address that patient directly because I live 2 hours away, for example. Mm-hmm. I can certainly work with the emergency room doctor and or the physicians on staff that are managing this in the outlying community and help them manage that problem, get the patient proper care, and or at least a transfer to a higher level of a service.
Right. I don't know how pointed I want to be, not for myself necessarily. I know you very well. To a degree, I'm doing the same model in Indiana, but I happen to be geographically closer. Like the farthest place is about an hour from my house. And it's 18 minutes by helicopter. So, but the thing is, some of these places that I'm operating at don't have 24/7 anesthesia. So even if a person came in and they had a surgical problem, I don't operate, like, for example, in Lafayette, which would be a bigger town around here who would have 24/7 anesthesia, and then have the ability to pull those patients, transfer them to myself, and manage them myself. So that is something that I think really influences the choice of the operation and the types of patients that you give the operations to in the first place.
Yes.
But what is the difference between doing that and not having a call team to be able to go back with the patient, even if you have your cell phone on, even if you physically could travel in, and being an itinerant surgeon?
Yeah. Well, I don't know that I'm going to answer your question directly, but I'm going to answer it this way. If I'm in International Falls and I do a procedure and that patient has an unfortunate complication 5 days later and I'm not there, that's identical to that same patient driving to Duluth to have that same procedure done. And they drive home and 5 days later they have that same complication and they end up in the emergency room in International Falls. It's identical. And so what we're trying to do is not be itinerant surgeons in the negative sense, but visiting surgeons in the very positive sense, where we can provide services to these community members and doing the right surgeries, minimizing your complication profile. Of course, you never get rid of it, but you strive to minimize that, and realizing that if these same people had to drive 2-3 hours for their surgery, they're in the same boat on day 5 if a complication were to arrive.
Mm-hmm. Have you had a patient that has come in and needed then a transfer to a center for something else?
I'm sure. I can't think of one right now, but yeah, the the physicians in these outlying communities have my cell phone number, and I never turn it off. And so when things come up, they tend to call. We solve the problem, and we get them down to the city.
Yeah, I have one example. I have many examples, okay, but one comes to mind. I had a lady I did a gallbladder on, and she came back mildly jaundiced and some residual pain. And I thought she might have choledocholithiasis and then needed an ERCP, which we wouldn't do anyway. So I guess even if I did have a call team, that wouldn't. But the thing is, this lady didn't come to the facility where I operated on her anyway. She came to another ER, right?
Yeah.
Who then got a hold of me on my cell and did call me, and I'm glad they did. But that's the funny part, is she didn't even come back to that same hospital. Not that I could have done anything different if she was there, but it's just funny. So then I sent her to be managed at a place where they had ERCP capabilities. They trained her bilirubins, and they didn't even need to do an ERCP anyway. But that's a good example of anybody that you do a gallbladder on could come back a little jaundiced. They could have a retained convolvulus stone. There's just every single thing. There's possible complications. I agree with minimizing, but you can't ever completely eliminate your risk profile. So I guess I support what you're doing, but I think that if a person wants to do it, first off, it's nice to have a seasoned surgeon coming in and doing that, who sort of understands those things. The second thing is, there's training tracks for rural surgery programs. If you can think about it, if you know where you're going, like I was trying to think all the way through residency about being in the town I knew I was going to go to, because I signed my contract as halfway through my second year. And I knew that I wanted to go back home anyway. And so I remember being on vascular surgery as an intern and talking to the vascular surgeon, asking her, we're doing a AAA. And I said, if this is an emergency and it comes into my critical access hospital, how would I, do my supraceliac clamp and everything? And we talked through, it exactly how I would make the incision bigger than her tiny hands need to be, and, where I would go with my clamp and everything. Of course, now the thing is, my point of telling you that story is when I was a resident, I didn't know what I didn't know, because now I know what the resources actually are.
True.
And I've got 5 nurses and 4 techs, and I've got a PCU and not an ICU, and I can't really run a vent. I can't really run a drip. And I really don't think at this point that even if that AAA came in right then and there, first of all, I don't even have any background or anything like that. So, I wouldn't do that case now. But, at least I was thinking about it. How do you know what you don't know?
Yeah, exactly. And honestly, when you do cover multiple hospitals, the resource set is different in each one.
Yeah.
And so your list and your case list might be different in each one as well. And I think the resource base and the access to the higher level of care, the proximity to the next hospital, probably comes into our decisions as well, Randy. When we do something like this, if something were to go awry, how would we manage that at midnight on a Sunday when we're away? And you ask about, is the cell phone ever off? And then the other way to ask that question is, do you ever take a vacation? Do you ever, run off with your family and do something different where you're out of the state? And I think the obligations are the same, to know those patients have a system in place where they can get to the care.
Yeah. I had a surgeon that I talked to at the North American Rural Surgical Society, and his perspective is very different than yours. And I'm hearing him out, and he said, if you're doing an operation, you have to be in town afterwards. And again, depends on the operation, but I said, how long do you have to be in town afterwards? And he said, it's whatever the global period is. So if you're going to do a gallbladder, you need to be in town for the next 90 days. But that doesn't that just does not compute, for me. But except for if you say, well, then I'm not going to take a job unless if I have a partner or somebody who's there when I'm not, and who always can take the call. I get around it by, if I'm going to be leaving the next week and I'm going to be going to Hawaii or go to Honduras or something like that, then obviously I do lower level things that have minimal complication. I do have a nurse practitioner that has the ability to write a prescription or open a wound or something like that. If she were needed to do that, she can't take somebody back for surgery though. And so I'm just kind of telling you where I'm at and explaining my perspective with other people, which is quite a variety of spectrum, which everybody seems to be motivated really internally by generally the right thing, the right care. But it's funny how you can come to different conclusions.
Yep. It's all an interpretation. I think I hear you saying you lean a little more my direction in the way you practice currently. And, I think and I wasn't a part of that nice conversation you had out in Denver this year, but the counter argument there would be if the patient travels 3 hours for their laparoscopic cholecystectomy, does that mean they need to stay in that town for 90 days before they go home? It's exactly the same. And I think that's the kind of logic that we're here to defy. The reason this, for you very young surgeons, this whole topic of itinerant surgery, when I went through my training, it was a horrible sin for a surgeon to do something called itinerant surgery. And that's what makes this discussion with Randy so pertinent right now, is that we're not looking to swoop in. It'd be a lot easier for me to stay in Grand Rapids every day and take care of patients right here. But I found that these communities have a need and a desire to have me travel. I can't live there, and I'm not staying for 90 days, but I'm willing to come and then put in place the post-operative care that we feel is appropriate. And I think it works, Randy.
Yep. Yeah, I could go on this topic forever. It's not even really part of the show, but I think it's relevant, and I'm glad that we talked about it. I did have, one other thought, if it doesn't escape me.
It'll come back.
All right, whatever. Let's move on.
Well, I was going to tell you, and I don't have a chopper.
Right. The helicopter, that shortens the commute, but then it's limited by weather, and certain things.
But pretty cool that some surgeons do. So that's pretty neat. Pretty neat about you.
When you can land direct, it makes a big difference. So.
Yes, sir.
All right. So why don't we move on to the next segment of the show, which is just to tell us what's so special about rural surgery that you've chosen to do this with the second half of your career.
My wife is from a very small town, small farming community. And I think that was probably part of the inspiration. My dad was from a small town, and that was part of the inspiration. My mom's from Madrid, Spain, so that's a big city. I wasn't going to live and work in Madrid either. But when I was going through my training, I think I just felt this draw to be a part of a small community, a place where I had an identity, a place where I might know the staff and the patients at another level than just going to work and having a different group of friends the rest of the time. So I just think it's something in me about this appreciation for smaller towns and having an identity in your community.
Today, we're going to do the how I do it on the most common operation that you perform, which is colonoscopy.
Correct.
This is one of my least favorite things to do, but it is also one of the most common things that I do. I don't want to discourage anybody else by saying that too much, that I don't like it, because it is so needed. It's just not necessarily why I went to surgery residency. And I really don't like it. So I have found ways to support people around me to do colonoscopy. And still, it's like the most common thing I do. But I've hired at one location a family practice doctor who does colonoscopy, and she comes in 2 days a month and takes that much of it off my plate. And then in another hospital where I recently started going, they actually hired a new family practice doctor just out of residency who has an interest in doing colonoscopy. He had more of like an experience in colonoscopy when he was in training. Did about 50, but it was more of like really pulling it out rather than inserting. So it's not starting from total scratch, but it's basically training him how to do it. And I have sort of taken on that challenge because it's good for him and the hospital, and then also good for me because I can train him how to work up my hiatal hernias, how to tattoo the colon the way I want him to do it and communicate things back to me. And then if I can do the surgical things that, I really want to do out of that practice as well. But if you're going to choose to be in one place, you almost have to do the colonoscopies because it builds your practice so much. And so there's just a lot of different ways you can take it. But when you were a vascular, my guess is there were like decades where you didn't do any colonoscopies. Would I be correct in that or no?
No, but I would say that in my residency, we didn't do enough colonoscopies because that was still back when we all hated colonoscopy. The gastroenterologist did the colonoscopy, and it was my goal in life was to never do a colonoscopy. But when you end up in a small community, you realize pretty fast that that's something you need to have a skill set for. So really, I did a lot of my colonoscopy training with my first surgeon partners. I joined a small group in the Upper Peninsula of Michigan for a short while, and they were general surgeons doing colonoscopies, and they mentored me through that, and I picked up the skill that way.
Okay. And so then how many colonoscopies are you doing in a day and in maybe a year at this point?
Yeah, I would say 5 to 10 in a day, depending on the location and the way they schedule. And so in a typical week, I might do 15 to 20. So, I mean, it's very possible that I'm doing 800 to 1,000 a year.
Okay. And when I talk on this show, there is one listener and they have possibly earbuds in, or maybe they're listening on their car, but they're not listening in a big group. Okay. It's not like people are coming together as a family and watching this show. It's one listener that's listening to us right now.
Yeah.
And some of them, so I like to talk to one person at a time. And I really appreciate you, by the way, listener, for listening to us, because it's a very cool and intimate thing to just have sort of almost a relationship. And you're really getting on this long form podcast, a stream of consciousness that is more authentic than anything else. It's very limited editing, But that being said, let's focus on one specific listener now, which is a medical student or a resident who potentially wants to go into rural surgery. Maybe they haven't already self-differentiated and they're just now learning that colonoscopy is important in a small town. All right. So the first thing I would like you to tell, now we're going to walk through a patient. Okay. So the first thing I'd like you to tell them is, what are the most common indications that a person gets a colonoscopy? And then we're going to talk about prep. Then we're going to talk about the procedure itself and the post-care. Okay. So start with the indications, if you don't mind.
All right. Well, typically, one of the most common indications we'll have is just screening for colorectal cancer. And of course, nowadays we have some alternatives. As a surgeon that doesn't too many colonoscopies, I'm a strong advocate for the Cologuard test. I think in the proper patient population, it's an acceptable alternative to what we do. So that, I think, helps to unload the colonoscopy backlog a little bit.
Who is an acceptable candidate for Cologuard?
Just simply speaking, to me, it's if you're truly an average risk patient, and they even say that on the Cologuard ads, they'll say it's a great alternative for average risk patients, which I've kind of condensed down to mean if you're asymptomatic and you don't have colon cancer in your family, you don't have a family history and you're not bleeding and there are no symptoms, yeah, you're maybe a good candidate for a Cologuard. Of course, review it with your family doctor, but yeah, I don't speak down on the Cologuard test.
So what if a patient had a prior Cologuard and it was positive, but it was a false positive?
Yeah, I like to follow them up with the colonoscopy, especially if it's my colonoscopy, meaning I did it. If someone comes in with a positive Cologuard test and they're truly asymptomatic and I come up with nothing, I like to follow up on them with another colonoscopy in 5 years. I'm kind of telling myself, what if there is a small adenoma that I missed? I'm not going to let that go 10 years, and another positive Cologuard in 5 years doesn't do us any good. So we just look again in 5 years.
Dr. Serap says he does EGDs on all those patients.
Yeah.
Finds a lot of upper pathology. Do you do that?
I've started to ask my patients some questions about that. So what I got from Dr. Serap on that was, if they have epigastric symptoms, his yield on the upper scope was very high. So the scenario here is, patient comes in with a positive Cologuard, the colonoscopy is negative, but if you really talk to them, they'll tell you, I've been having some epigastric discomfort. And he said so many times he'll do an upper scope on those people and he'll find legitimate pathology, anything from peptic disease, maybe a positive H. pylori infection. That's what you're getting at, right, Randy?
Correct. Yeah. That was an interesting talk. I usually go out of my way to dig for the epigastric symptoms ahead of time, and I'm usually doing the double scope ahead of time, even if they're there for positive Cologuard, but not always. And so it's something to consider if they come back and it's negative. But you do a follow-up scope in 5 years. That it makes sense to me. There's a textbook in a couple rooms over from where I'm currently sitting. I bought this clinic that is the clinic I grew up going to as a kid. And I'm in the basement right now. That's where I put in my recording studio. And there's a textbook from the 1980s. And it's from one of the doctors that used to work here. And it's about colonoscopy. The whole textbook's about colonoscopy. So I cracked it open just out of curiosity after I had bought the building. And it says, because colonoscopy is so expensive and so limited and so few people know how to do it, this is in the 80s. Yeah. We do not recommend screening for the general population, only a very high risk candidate or someone that has symptoms or whatever. And then there's all these pictures in there of live fluoro watching the reduction of an alpha loop, and it's just so incredible how far we've come to where now it's not 50, but it's 45 for an average risk person for screening colonoscopy. And then every 10 years thereafter, as long as they don't have polyps. Now, if you do have polyps, do you have any guidelines you follow, or how do you determine when they get their next one?
Yeah. Through the years, this has been a moving target, and I've worked to try and come up with an algorithm, some consistency on how to advise my patients. But you had everything from the gastroenterologists had one school of thought, and the American College of Surgeons had their school of thought. And then there was the American Cancer Society that had recommendations. So I do have an algorithm. It's been challenged recently, even out at our meeting, Randy. I know they're starting to talk about 6 and 7 year intervals and 3 and 4 year intervals for certain things. But to me, I'm really still sticking with this 5-year follow-up on adenomas. So my basic first thing that I teach medical students or rural residents that I have the luxury of encounter, it's every 10 years. We do colonoscopy every 10 years. If you have a first degree relative, we shift it to every 5 years. If you have an adenoma, we put you in the 5-year group. If you have a family history and an adenoma, I'll sometimes go 3 years. That's a 3-year. It's almost like the risk factors kind of compound a little bit. Villus adenoma, tubulovillus adenoma, we shorten the interval as well. And again, when I try to find this, even on UpToDate or any of these resources that we have, it's really hard to get just clear answers. So I've typed it out, and I have that at all of my facilities. And every time I go, we go over all the pathology reports from the previous day's work and give the patients a call on our recommendation for their follow-up. But like I said, the pathology report alone is not enough to give a recommendation on follow-up. I want the pathology report and their family history and my operative report together. Then I can give recommendations on when they should come back.
Yeah. What you're describing there is something that I don't think a lot of people come out of training appreciating. And that is that, first off, so we're doing ABSITE every year in training, right? And it's a multiple choice test, and there is a right answer. And in the real world, what are we really trying to do here with screening colonoscopies? We know that the average risk person in the United States has a 4% chance of getting colon cancer in their lifetime. So 96% of people, we're going to scope them 4 times at 45, 55, 65, and 75, maybe a lot more, because if we might find adenomas that actually wouldn't have gone to cancer.
Absolutely.
And we're going to do that to 96% of the population so that we can detect earlier the colon cancer in the 4%. And then you start to realize, like I have now realized in 5 years, and you're realizing that if somebody has had an advanced adenoma in the past, or they had colon cancer in the past, or they had a family history of colon cancer, there are always places where the guidelines will stop, and you're going to have to use your professional best judgment. I would like to share the guidelines that I've used since I got out, which is the ASGE guidelines, and those you can just do a web search and find, and they're free. But it's funny because that's the problem, is if you have 3 or 4 different places that are all releasing guidelines and then they disagree, then you start to realize, oh, I'm the doctor and I'm the one that's going to make this recommendation to this patient. It's kind of like any other professional relationship. If you're an attorney, if you're an accountant, you know the facts, but a couple of different people might come to a different conclusion. That's where like the 3-year for 3 or more adenomas, right, or adenoma greater than 1 centimeter comes from. That I do that very often. But it still depends. And if you've got mom and dad both had colon cancer and you got one adenoma, like, I don't know what's the right answer. So, then there are people that have scopes for symptoms too. So I'd like you to just, briefly talk about that as well, but and anything else you had to add.
Yeah, no, I really appreciate your summary there. And honestly, I think ASGE, is that what you refer to?
Yeah, American Society of Gastroenterology.
Gastroenterology. So yeah, the gastroenterology does overlap pretty well with what I'm doing, and it was when you summarized it. For example, the adenoma over 1 centimeter or more than 3 adenomas is why I like to have the pathology report and my operative report when I give recommendations, because in my operative report, I'll always estimate the size of the lesion that I've removed. And that is such an important part of this. In addition to colon cancer and colon cancer screening, it seems like it's rectal bleeding is another common indication for colonoscopy. Sometimes it'll be a recent bout of diverticulitis. That one's a little confusing. They'll have a bout of diverticulitis. They'll manage through it. They'll be in to see their family doctor, and the family doctor will say, you should have a colonoscopy because you just had diverticulitis. So that's another indication. Diarrhea, chronic diarrhea is a common indication that we deal with. And I guess that's a pretty good short list right there. So rectal blood, anemia, diarrhea, recent diverticulitis.
Some guidelines that I found, I can't remember which guidelines this is. Everybody that has chronic anemia needs a colonoscopy, except maybe a woman that's in menstrual age. You could consider going a little bit longer. But yeah, definitely, and if you're going to go in and try to build a practice, you want to talk about that, find a hematologist that knows that as well, share that together to the primary care base. You'll find a lot of colon cancers that way too. And then the chronic diarrhea patient, what you're specifically looking for there is microscopic colitis or collagenous colitis. And so what I do is random biopsies, usually in the ascending, transverse, descending colon, two bites each, send them then together collectively, 6 pieces in a single cup, and I call them random colon biopsies. Is that what you do with the chronic diarrhea patient, or how do you do it differently?
No, exactly. And I was a little bit into my practice when this light bulb went on. So this is a great example of how you can make it through an entire surgical residency that isn't focused on colonoscopy, and then work in a community and pick up the skill of colonoscopy, and then do a bunch of them. And then finally, over a cup of coffee with the gastroenterologist, you realize that, no, when I have a middle 50-year-old woman, especially with chronic diarrhea, I do random biopsies. And it was like this light bulb went on that, okay, there's this diagnosis, microscopic colitis, collagenous colitis. And I do a lot like what you just suggested. I'm a little more aggressive with the biopsies. I don't know. There's probably some good ASGE guidelines out there for that as well, but I get about 5 bites with each pass. So I like that, the biting forceps with the spike. And I feel that with that spike, I can stack 3, 4, 5 good bites. And so I'll just slowly withdraw the colonoscope, trying to get my complete colon surveillance in at the same time, colon cancer surveillance, and just pluck random biopsies along the way. Early in my practice, I was doing separating them into different jars and telling the pathologist what was coming. But now I've come to putting them all in one jar.
Yeah, me too.
and just let them look. And, it's a couple times a year they give me the diagnosis of microscopic collagenous colitis. And it seems to really be helpful to the patient and the family docs when we do that.
So who manages that condition when you find it?
I hand that back to the family physician and let them kind of work with that.
Yeah. Have you ever heard any long-term follow-up from those patients? Because it can be very dramatically improved.
Yeah, I have. And I agree with you on that. But again, with the family docs kind of working on them and seeing them more on the week-by-week basis, they can really change some people's lives.
Yeah, it's one of those, it's just when you just take a pill and you're all better. People feel pretty good about medicine when we have the opportunity to do that. The last thing on the indications is, I agree, diverticulitis. So how long do you wait until you scope them?
Yeah, it's sure nice when they're asymptomatic. And for some reason, 6 weeks jumps out at me. What are you doing?
That's what I do too.
Yeah.
What if they had a scope 9 months ago?
Yeah, that's the confusing thing. I think as an endoscopist, we always have to realize that it's not a perfect test. I remembered a mentor surgeon talking about that colonoscopy, it's probably better than a guaiac card, but it's not a perfect test. You might miss something. And so to be willing to admit that, I think, is healthy as a physician and as an endoscopist. That's always tricky. Or the other way to look at that one, Randy, is they had a colonoscopy 9 months ago. Their dad had colon cancer, and now they're bleeding again. And it's not on the toilet paper. It's like blood coming down into the toilet water. Do you look again? If it was another surgeon in a small town, you look again because you're not going to let that patient miss anything. So do you rescope on your own patient? I don't know. Back to your question.
That is a very funny way of thinking about that, because if it was somebody else's patient and they showed back up with rectal bleeding, there's no question I would scope them.
Well, the other way to look at that is they go down to the Mayo Clinic in Rochester. I did their scope 5 months ago and I cleared them. Now they're in Rochester. The first thing they're going to do is scope them again.
Right, of course.
They're not going to take any chance on that. So, should we have that same threshold when our same patient loops back to us?
There's this thing called do to others the thing that you would want done to you.
Yeah.
That's a good rule, right? That's it. I would want myself rescoped, but at the same time, I guess what I would really want is I would want to be educated about the situation, and I would want to make the decision for myself. It's probably what I would really want. So if you tell the patient, and the other thing is, I do this with, you're talking about like surgical, this is what I was going to talk to you about earlier. I have a very frank discussion with patients about what my resources are in a small town very frequently. So I say, like, for example, especially if I'm saying no to a patient because they have a bad heart or something like that, I say, look, it's me and one CRNA. Her name is Jing. She's very good. I like her. I trust her. I would go to sleep underneath her care as well. But if you don't want me to be coding you with just me and Jing and the resources that we have here, we would be calling literally the ER doctor to come over and help us. Yeah. And if there was a hospitalist in the building, we would be calling them to come help us too. But if you go to XYZ other hospital where there's whatever, 15 ORs. You push a blue button on the wall and 5 anesthesiologists come in and everybody's there, and one person can put an A line, one person can put a central line. You got plenty of people to code you. And I talk to them just like that. And usually when you explain it, they understand what the difference is. That doesn't mean that we shouldn't do, just because anybody could theoretically code, it doesn't mean that we shouldn't do the things that are extremely unlikely to have those things happen. But if you tell the patient the risks, then you document that you said it. That's what I would really want if I was a patient.
True. I think that's valuable. And I think to have a careful threshold, and I think the threshold is different in every community, and it's based on the resource base in that hospital. But we do the same. I do all my colonoscopies with CRNA. That would be another great topic for a podcast. Early in my practice, it was all self-directed IV conscious sedation. But now I do all of them with the CRNA in all of my hospitals and facilities. And the CRNA is a very good final filter. I've looked at the chart. The family doctor sent them for the scope. They've considered the situation, but the CRNA needs to buy in completely. As a matter of fact, I always tell the RNs, the surgical team, that they get a vote too, that if anyone's ever feels that we have a patient that's beyond the risk profile that we should manage at the facility, I want to hear from them about that. So we just everyone has the ability to stop the chain. Yep.
Do you ever do moderate sedation for any other procedures or any reason at this point?
I do. In certain situations, even to place a chest tube, it's something I would definitely. I'm happy to have that skill, and something I would definitely keep keen on. To me, when you go that way, I was just taught, make sure you're properly monitored and have some backup. So if we're going to give anyone any sedation, we get them hooked up to the monitor, and we still would do that.
Yeah, I need to have that as a topic at some point, moderate sedation for how I do it, because I think it's a great skill to have. You can kind of offload your CRNA, like if you're in a place where there's only one CRNA, and if you can get some things done, and it's really nice to just have an option for the patient. A lot of things can be done under local, or you can use your CRNA, but there's this sort of middle ground, which is moderate sedation now, I guess is the correct term. Okay, so we got the patient. You're taking them now. You already touched on anesthesia, which was one of my questions. And how do you position the patient and prep? Actually, how do you prep the patient first and then position them?
Okay, so really quick on the prep. A lot of the gastroenterologists in the big city are insisting on this full gallon Go Lightly prep. I still use that here and there, but our go-to prep has become this Miralax prep. Miralax with the Dulcolax tablets and Gatorade. And, I don't know how this got accepted and started and considered an acceptable alternative, but when people follow the instructions, we get really good preps. The problem is if they don't get good, clear instructions, sometimes we don't get great preps. But that day before is so important. So we've come to use the Miralax prep. Seems to be more patient-friendly and predictable, and we get good results.
Let me describe exactly. I do a lot of different things, but let me describe exactly what that Miralax prep is, and tell me if this is what it sounds like for you. So the day before, clear liquids only, and then they drink all 238 grams from a jug of Miralax in the afternoon. Basically, we'll say maybe it's 1, 2 o'clock, whenever you want to do it, or some people do it a certain number of hours before their scope. So if the scope's at 7 versus a scope at 2 o'clock in the afternoon, the time would be a little different. And then they usually have, is it 64 ounces of Gatorade? Something like that?
Yeah, and more if desired. So at least 64 ounces of a clear liquid.
And you tell them no reds?
We tell them no reds, but I had one surgeon up here that said, if I can't tell the difference between red Gatorade and blood, I have a problem.
And they take 2 Dulcolax tablets just once, is that?
I think once at the beginning.
Yeah.
Yes. Yeah.
Okay. I agree. Basically, it's 2 32-ounce bottles of Gatorade and a bottle of Miralax and your 2 tablets of Dulcolax, and that's it.
And the clear liquids the day before. And the other thing we do is we talk about no grains for I'd love to say for a month before, but I think it's 3 or 4 days on our prep sheet. The one up here that gets us is wild rice. Wild rice is exactly the size of the suction portal on the colonoscope. So you can fill a colonoscope with wild rice fragments. And so avoiding grains, I think, a couple days before, clear liquids only the day before, and then the prep as you outlined it. And we do pretty well.
Yeah. So I have Go Lightly at one place, and at that location, this is kind of a hangover from previous practice that was absorbed by the hospital, but I get a great prep out of it and I don't complain. But the other issue is people not going to the store and buying it and knowing the right things to get, and that place, we do the gallon jug of prep with a sheet stapled onto it is the Dulcolax. Here you go, and give it to them. Yeah. And they don't sell it to them or anything. They just give it to them for free, because the other issue is the $10 to do that is a barrier for some people in our community. They at the same time, the $8 cigarettes are being consumed. Yeah, but that's neither here nor there. The money would feel like a barrier. So I just go with it because that's what they're doing there. But if somebody asks me for something different, I have the Miralax prep printed out there. I give them that option. And then sometimes people are like, I don't want to drink that nasty prep. Give me the pills. What do you tell them?
We do have a one-page description of what we call the pill prep. That I have no idea what that protocol is, but it is available. Maybe once a year we get asked for that. I'm not opposed to it. Requires drinking a bunch of water with the pills. I don't know. What's your experience with that one? Do you allow your patients to do that if they request it?
Yeah, they ask me for it all the time. Yeah. And it is, it's the one that I usually use is called Sutab. And I think it's 32 tablets. I always have to look it up every time. No, it looks like I'm looking it up as we're talking here. It's 24 tablets split 12 and 12. And you have to drink, a bunch of water. The problem is I have called it into the pharmacy and I've warned patients about it. And I'm like, it's often not covered by your insurance and it's expensive. Mm-hmm. So and they'll say, oh no, I still want it. I'm not drinking that prep. So then I do the Sutabs and then I get a call later. Hey, it's $250 at the pharmacy. Can you actually just teach me about the other prep instead? Like that has happened many times to me. So I hate it whenever I hear that because I know it's just going to be more work later, but whatever.
I think what I would do in that situation, they ask for the pill prep. My typical speaking might be, oh, you had the Go Lightly last time. We have a new one that's a little easier. Tell them about the Miralax, see if I can't get them to bite. And then every now and then, if they just insist, we do allow that pill prep.
Yeah. Okay. Wonderful.
I was just going to move on to your good question. I have a couple little things about the beginning. I love to interview my patients in the colonoscopy room. There's a couple of my facilities that don't allow that. They say that the patient needs to be consented and ready before they enter the room. And I've always argued, well, that should happen before they're sedated. But I like to interview my patients in the procedure room because I like the team to hear the interaction. I'm worried about the bleeding, or they'll say I have chronic diarrhea, and then everyone knows, we're going to do random biopsies. Or my mom and dad both had colon cancer, and all of a sudden you just the antenna goes up a little bit. So I like to interview the patients in the room. We do a timeout. I'm sure everybody does the timeout, even for endoscopy. And then I do put my patients left lateral decubitus. I like to get their knees tucked up a little bit towards their chest, kind of into a sitting in a chair kind of position. I like their knees up because it just makes the perianal exam a little easier. And what the anesthetists have been doing lately is actually raising the head of the bed a couple clips, getting the shoulders up a little bit, kind of an anti-reflux maneuver. And it doesn't affect me. It doesn't bother me when they move the shoulders up a little bit to elevate the head of the bed. And then, time out, we get started and I get going. I always have a scribe in the room. And if I don't have my scribe and typist there, I ask the RNs to make notes for me because sometimes, you can get pretty carried away. You get into your fifth or sixth polyp and you're starting to forget exactly what you just did. So I start out by checking, and I'll tell them, write roids down. If I see soft external circumferential hemorrhoids, I'll write that down, because when I get to sit down and do the dictated report, I want to know that. So I get a good look, and then everybody gets the finger check. Every single patient gets the digital exam at the beginning. I always I put my gloves on, and then I put a second glove on that hand, get my digital exam done, throw the outer glove away, and I'm ready to go.
Digital exam, when I was in medical school, we had to have these kind of fake patients come in, and they pay them to like do this thing. And one of the fake patients was like this prostate test. And I thought, I kid you not, that the digital exam was like, I was going to have some sort of like digital thermometer or like digital instrument that I was going to do. And then when it hit me, like, oh, digital exam, whoa,
Yeah,
yeah,
exactly. The other thing, it really should just be called the finger check, which is much more descriptive. I don't know where this term digital exam came from, but no, the good old-fashioned finger check. And I think, and honestly, that's your chance to find the anal cancers. And when people ask me why that, I think it's the hardest part to visualize. That anal canal is really tough to see with the flexible endoscope. And so your finger can just kind of take away any concerns there. But I found a couple of anal cancers. You open things up, you put your finger in, there's something hard there. It's not right. And you know it right off the bat. And that patient needs a little extra. So my mentors got me doing that right away. It's just every time. Good finger check.
Do you ever break out a Hill-Ferguson anal retractor? Like in that situation, you did a retroflexion, you still can't really see, but you feel something, or any other thing? Do you do it like that day, or do you set them up for an exam under anesthesia another day, or how do you do it?
Fortunately, I haven't seen a lot of these, and I think my bias would be that we're in there to do a colonoscopy, and the next patient's late now, and so I just keep going. But I set that patient up for a biopsy and a speculum exam, and we'll get some tissue for him.
Yep. Okay. So anyway, carry on.
Yeah. And so once they're in position, I have my finger check. We grab the flexible colonoscope and get underway. I think that the insertion of the scope is really the learning curve part of this, and it's amazing how different your first colonoscopy is from your 1000th colonoscopy. And the tricks and the ability to manipulate that scope that you acquire with time. And there's no way to read a book on it. I don't know if you agree with that, Randy, but you hold that scope and you pass it. Your left, right, up, down dials are good, but everything in between with twisting that scope is really how you move that scope up and through the colon. So goal number one is to get that scope up and into the cecum. You talked about the alpha loop earlier, and really the challenges going through the sigmoid. I think that's really a lot of the learning curve again. I have a technique. What I try to do is get up and into the descending colon. And then a lot of times I'll find myself gathering the scope back towards me, trying to straighten that piece out and then go forward again. And that works quite often. I don't know, comments there, Randy? Otherwise, I'd move on.
Well, I have one question before you start the colonoscopy still, which is you mentioned in kind of in brief that you're meeting these patients the same day, which I think is what most GI doctors are doing, but it's not what I'm doing it most of the time. Is somebody doing a pre-anesthesia evaluation on these patients?
Really just their family doc, me, and the anesthetist. But when me and the anesthetist do our pre-exam, it's based on the chart only. We haven't laid eyes on these patients until they show up for their colonoscopy. Mm-hmm. So when I go over this with the staff at various hospitals, I've drawn a hard line, and I tell them, this is a unique situation. I would never do a surgical procedure like this. If I'm doing a gallbladder or a hernia, even in these remote locations, I'm not going to do it the day that I met the patient. We're going to set up a clinic visit. We're going to go over the risks and benefits. We're going to spend some time together building a relationship, and I'm going to schedule you for a month from now. and then we'll come in and take care of things. But the endoscopy, to me, is an exception. We let the family doctors schedule these, and I show up and I do the procedure. Now, I interview them before we sedate them, but I haven't met them before that. Is that kind of what you're getting at?
Yeah, it is what I'm getting at. What I was saying is, does, for example, anesthesia chart check some of these people and then end up canceling them? And do they cancel them the same day, or do they do it ahead of time? Because by the time they come to you, they're prepped.
Right.
Or even like your nursing open suggestion for canceling. Like, we normally really hate to cancel colonoscopy. It's like they're more willing to cancel other things than they are colonoscopy, because that poor patient's already prepped.
Agree completely. So yes, first of all, when the family doctor puts them on the schedule, they've given their initial consent that they feel they're clear and ready to go. The anesthetist, though, do a formal chart check, and we strive to do that 3 to 7 days ahead of time for the reasons you just said. If there's a red flag in that chart, we don't want to find it on the morning of. But that said, every now and then there's still a patient where on the morning of, the right thing is to cancel them. And they'll say, but geez, I took my prep. And then we have to just have that heart to heart with the patient and explain to them that we're sorry, but the right thing to do here is to wait. And the prep is a nuisance. We admit that, Mrs. Johnson, but we just need to cancel it. We need to get your cardiac workup completed, and then we'll get you right back on the schedule.
What percentage of your cases do you think cancels of colonoscopies?
On the day of, I'd say 1 to 3%.
Yep.
Very low.
Seems acceptable. Yeah, sure. So, and the other thing I would say, my personal bias on, which is also the bias of every single cardiologist everywhere, is there's no such thing as a quote unquote cardiac clearance for surgery, even though that's what we say. But I never write that in my own notes ever. I write preoperative cardiac risk stratification and optimization. That's what I write in my note, because that's what it is. The question is, does this patient need an echo? Do they need an angio? Do they need a stress test? And I'm not going to be the person that orders that test, so I'm going to send them to the cardiologist for their preoperative cardiac risk stratification and optimization. And then they're going to come back to me and they're going to say the patient is optimized for the procedure. I think they're low, medium, high risk. And then they're going to have some cardiac risk no matter what, but we've done everything we can to optimize them.
Yeah, I agree with you. And I think when we use the term cleared, it almost means the chance of a complication is zero.
Right.
They're clear. So their risk is stratified and minimized, and they are now optimized. But yeah, of course, they're not risk-free. The other one that we talk about a couple times a year at the medical staff meetings at any hospital, big hospitals and small hospitals, is when the family doctor orders the echocardiogram and the colonoscopy at the same time, and no one discriminates over what happened first. They know they need their colonoscopy and they need an echo because of their chest pain. And sometimes because we can get them on sooner, they get on for their colonoscopy first. Well, that's one of those things where the anesthetists are savvy enough to know, hey, wait, this doesn't add up. We need to cancel this before their prep.
Yeah. And I'll say one more thing, that I have moved towards very much a nurse practitioner, strong support in clinic. And I have an awesome one, so that helps, I would say. But, like last year, both my kids got their tonsils out, and they went down to Carmel and the IU system with the Riley Hospital and all this stuff. And they both saw a nurse practitioner. Nurse practitioner said, yep, agree, need tonsils out. It's going to be at some later date at one of 2 hospitals by one of 6 surgeons. We'll call you and tell you who it's going to be. Yeah. And I actually was perfectly fine with that, because the thing is, if it becomes so routine that it can work well in that kind of a model, I guess I was just comfortable with it. And some people don't like that. Some people also, some surgeons don't like that, and some patients don't like that. But that's what I have moved towards with Taylor. And at first, I had wound care, and I needed it taken off my plate. So Taylor did wound care for me. Then I was getting eaten up by, basically, I do think there is a benefit, and you definitely don't have to do this. I would do open scheduling if I could. But there's a sort of an expectation, because a lot of primary care docs have done colonoscopies in my towns that I'm in, and the patients want to see you before, like they're expecting a clinic visit and a lot of times. And also then we do our own kind of like not cardiac clearance, but like a pre-anesthesia eval. And so we have also very low cancellation because Taylor's basically, she's a family nurse practitioner. And so she approaches it thinking of the patient's heart and risk for surgery, ordering some tests and getting them to cardiology when appropriate. So then I don't have to, and because it's her time, I'm more patient about it. I don't even know about it. Where was I going with all this? What happened is I was getting eaten alive with the colonoscopy clinic, time. And so then I said, hey, listen, this is how I think about colonoscopy. Like, could you be this buffer for me? She said, yes. And then that went awesome. And so a little bit later I said, hey, this is actually how I think about inguinal hernia. Do you think you could handle this? And then she said yes. And so she started doing inguinal hernia. I was like, well, I'll still keep the ventral hernia, because that's tough and it's complicated. And then after a while, I was like, let me tell you how I think about ventral hernia. So now she's like, I would say at the level of maybe a second or third year resident in terms of her decision making. And we talk basically every day. Gallbladder too. That was an early handoff, but even now, like she's incredible because she had a patient that came with some abdominal pain or something, like some weird complaint. Wasn't really, I don't think it was for colonoscopy, was really the complaint. On physical exam, she felt a cecal cancer, got a CT scan, lined him up for me. So she's doing a great job. And I usually have her see the patients pre-op and we bring them back post-op and explain it. And I think that it increases understanding and compliance with the prep and compliance with the follow-up recommendation. And we sit them down and show them physically the pathology and say, this is what it is. And this is what guidelines we're following. And this is what we recommend next. So people leave the office with a really good understanding. And then we have an opportunity for like them to give us some positive feedback and say, everything went great. And then we say, okay, you're dismissed back to your primary doctor. And we get our little pitch in there where we say, don't forget to tell them we took good care of you, and all that stuff. And sure. It's just there's so many ways that you can take your practice. Nobody is talking about this in residency, or they didn't to me. And that's like the art of medicine. And I feel like it's worth exposing that there's a lot of different ways to do it and talking to different people like yourself who, just a lot of different things can be done a zillion ways. Anything to add to that, or shall we move on with
just that I agree. And so in these smaller communities, I don't have the luxury of the nurse practitioner, physician assistant, but what a great way to duplicate yourself. So when your practice is mature enough that you can bring a person like that on, you can just duplicate yourself to the point where you can become so much more efficient. In the absence of that in these small communities, I find myself doing the preoperative visit. I have insisted on meeting all my surgical patients in advance, but the colonoscopies are the exception. And that's why that preoperative visit with my patient is so important. So even the colonoscopy patient, I want some FaceTime with them, establish at least in a short time, establish a relationship with them before we put them off to sleep and take care of them.
Well, one last question. Do you charge an E&M visit for that conversation that you have in the room?
I do not. But going back to something you said, in that group of patients that say, well, geez, I'd really like to meet him first, or I have some questions before the day of my colonoscopy, we always make room in the clinic for those folks that want and desire that. And then, of course, there's a charge for that visit.
And then your call, when you describe the path, are you making the call or as a nurse?
I'm having the nurses do it after I've written a note to summarize my recommendation.
Okay. And if you had to make the call, would you charge an E&M for that?
I don't, because I'm not smart enough. Is that something that we can and should do?
I don't know. I think you could charge it as a telehealth. I think that if you talk to the patient about it ahead of time, I think the patient many times would be dissatisfied. But when you physically come into the office and you sit down and Absolutely. They end up getting a charge afterwards, it's a little bit, I guess, easier to sell. But there's some people that have been practicing around me who bring them physically back into the office, sit them down, afterwards, talk about the pathology, and then don't charge, which I think you could argue that that's fraudulent when you would bring some people in, like when you're doing the service and you don't charge there. But I don't want to go there necessarily and say,
right. Now, if we get a cancer diagnosis, we're going to bring them back in and talk with them about it.
Right.
If it's a tubular adenoma, the nurse is going to call and say, we recommend a 5-year follow-up. We haven't been charging.
Everybody is not charging for something that you did on a Medicare patient is just as much fraud as charging for something that you didn't do.
Yeah.
But the thing is, nobody has gone to Medicare jail for not charging for something that they did.
Well, I think the other point something you brought up earlier is the whole global follow-up period. And I think on the colonoscopy, it's 0 days.
Right.
So if you bring someone back a week later to talk about their results, to me, that's an obvious charge.
Right. What if you consult on a patient in the ER or on the floor and then scope them the same day? Then you would drop a...
Sometimes I will, and there's that special modifier where it includes a decision to operate.
Right.
We usually, document that the consultation in the ER included a discussion and a decision to go to the procedure, and then I think typically that's paid and very justifiable.
Yeah, 100%. Okay, great. So the people that trained me at Mayo, we went to Owatonna, Minnesota. There were 3 people out there doing scopes. They did 1,500 a year. We did a 6-week block rotation. They clicked the timer and started it, and you go as far as you can go for 10 minutes, and then we're taking over because we got to do 1,500 a year. Yeah. And so, some people on their first day, they're getting all the way through. There's colonoscopy trainers. I actually learned from the colonoscopy trainer several little tricks and tips. One thing is just jiggling the scope is a great trick. But skiing through the moguls is something that was told for like the rectal valves, skiing through the moguls. Yeah. And then it's a series of right turns, clockwise turns, to get up and around the question mark of the colon, basically. People get hung up in the sigmoid colon. The other place to get hung up would be splenic flexure, and you can get hung up in the transverse colon, and then also the hepatic flexure, all of which require different tips. So I believe we're talking about being in the sigmoid colon, and then you kind of brought up the alpha loop. So that's where the scope's going up and your scope's coming back around in front of it. And to reduce that loop, if you can't go forward, do you do anything in particular?
Well, I think that we advance the scope up and through the sigmoid colon. If we can't reduce it, a lot of times just to stop and come back, and as you're pulling back on the scope to turn the scope, it will help to alleviate that loop. There's also the stiffener on the scope that I think is perhaps oversold, but there's a purpose for it. So I like to advance my scope in the loose setting. And if I run into trouble, I like to draw back and then consider stiffening it as I advance again, hoping to keep that loop as a non-loop. As far as right turns and left turns, Randy, I'm not as mechanical as that. I know that if I would watch myself next time, I'd do a better job of talking about if I'm going right or left. But it becomes so instinctive after doing many that it's more of a generalized push. More push is definitely not the answer, right? That's one of the ways we can injure a colon. So we need to have a level of delicateness, awareness of the tissues and what they'll tolerate to do this job that we do. Why
don't we pause there? Have you had perforations, and do you mind sharing about that?
Yeah. Perforations. I think every time we do have one as surgeons, it's a bummer, but it reminds me of, some of my first surgeons I worked with that said, if you don't like complications, you can't do these procedures. And what we work to do is minimize our complications and admit that we never make that 0. Early on, I remembered navigating a sigmoid in a patient with diverticular disease, and I pushed the scope right through the wall of the sigmoid. I was looking at small intestines, and I knew in a split second what had happened. Fortunately, I haven't seen that one happen for a while. But that was from just too much forward pressure and not an appreciation of the anatomy and the tissue and where I was.
Do you remember any details about that patient? Like, were there any, aside from the diverticulitis that would cause inflammation, woodiness probably in that area, were there any other comorbidities or anything that?
That's 20 years ago. I don't remember,
Yep.
but it was an older gentleman that I'm sure. Exactly. And when we get these complications, you don't want to brush them off, but typically there's an underlying disease process or something that led to it. The next collection of perforations, often in the setting of a biopsy. There's a lesion and you're trying to remove it and you're maybe a little too aggressive, and it brings you back to the fact that we didn't put the lesion there. And in the old days, that lesion would have required surgery anyway. But just walking that fine line and reminding yourself, what's the goal for the day? Is it to get some tissue and biopsy, diagnose this thing, or is it to remove it? And if you really know you're not going to remove it, then just get some tissue and try to have some judgment. One final comment there would be the old hot forceps. I had bad luck with the hot forceps. I would be removing a small sessile lesion. The ones that I remove now just with a cold forceps and just pluck them. I, early in my practice, was using the hot forceps to do the same thing. And I recall a perforation doing that. And I think that's one of the key reasons I would say I almost never use that hot forceps anymore.
What do you set your cautery on when you do colonoscopy?
And it's a little bit different at different facilities, and 30 rings a bell. I think Valley Lab 30, but it depends on the equipment, I think. And that's why at every facility, when they say, what do you want the cautery on? I say, I have it written on the top of the machine. So I want it to be standardized, and I want, if that gets bumped or changed or one of the other doctors is in here, it should be on 30. What do you use, Randy?
I use 18. But if you have 30, it's just, you have to know what you're setting it on, because the amount of time, and I still do quite short bursts, but if I was on 30, I would do even shorter bursts of cautery. And I do use cautery on most of the time when I snare. I would say but it's 18, and it's just a little tap as I'm cutting through. I feel like it has reduced my bleed, oozing and everything afterwards. And hot biopsy. So do you remember, like, on that hot biopsy perforation, how big the lesion was? Because I do use hot biopsy as well, and so I can tell you exactly like how I think about it, but I don't know that it's necessarily right either. That's
No, what I'm saying is those little sessile diminutive lesions that are sometimes even hyperplastic. A lot of times we'll take those, the nurses see them, you're obligated to biopsy that thing, and I'll just pluck them with the cold forceps. I've been very fortunate to not see bleeding with that technique, but in the past I used hot on those and I had a perforation. And so in that series, it's biased me for the rest of my career that I am chicken to use hot forceps. Now, fast forward to the snare, I almost always use cautery with the snare, even though nowadays there's a trend to more cold snaring.
Yeah.
And there's this crazy argument that the bleeding rate goes down when you use the cold snare. You've heard
I have heard the argument. It's not been my experience, but
right, same. So I still use cautery. I think that I wish I had the machine. It might be 20 that we're setting it at, Randy. I don't know. I just, when they ask, I look at that sheet because it can be variable depending on your equipment.
Yeah.
But going through a larger lesion, I do like to have that heat kind of following it as I bring the snare through the tissue.
So since we're on this topic, why don't we keep talking? We will come back to getting the scope all the way over. I got a few more things I'd like to ask about that, but you have a larger, easy decision. If you got a pedunculated polyp, you're snaring it off. For me, 3 millimeters or less will fit in my jumbo forceps. And I usually actually use a hot jaw. I'm much more aggressive in the rectum with the hot forceps, much less aggressive in the cecum with the hot forceps. You're thinking about the thickness, right? But one thing about the hot forceps that I do like is it just makes just a little rim, because rather than using the snare where you're taking normal mucosa around it, your margin may not be there with a cold snare. a cold biopsy forceps rather than the snare. And so I'm thinking that it's like, it's not the penumbra, but it's almost like the penumbra around it, that you're kind of maybe destroying the rest of that polyp. That's just kind of how I think about it. So usually 3 millimeters or less, use hot biopsy, and 4 millimeters or bigger, I use the snare, and basically know the rules, follow the rules, and then break the rules, right? So that's for every single thing in life. And for the cold biopsy, then I'm usually taking a cold biopsy if it's something that obviously I'm not going to be removing because I think it's cancer or something, or I'm doing my random colon biopsies, or I've got inflammation that's when I usually find myself using the cold biopsy.
Yeah.
We talked about the pedunculated polyp, but what about that polyp that's like 2 centimeters or bigger and it's flat? Do you do any special techniques like mucosal saline lift, or what do you do in that scenario?
I do not. If there's a lesion, I typically use the hot snare only and lift it. If there's a scenario where I'm able to get 80, let's say I get 80% of one of those big complex flat sessile lesions and it comes back as a tubulovillous adenoma. I get my tissue. We didn't have a complication. It comes back as benign. This is one where I will send them away to the gastroenterologist, partly for a second opinion, partly to do a saline injected technique, and just to get them plugged into another system and to give myself some backup on that. So I haven't done the saline injection. I haven't used the needle for much anything at all until I started tattooing. That was really the first time I started injecting into the colon.
Yep. So the EMR, endoscopic mucosal resection, I also send that out, but I know several rural surgeons that do that themselves.
Yeah.
There's a mucosal resection, and then there's a endoscopic submucosal. Basically, it's going a layer deeper and actually doing more of a dissection. That I obviously definitely do not do, and so I don't know that of any rural surgeons personally that are doing that as well, although they could. But basically, I will send those out. Those would be polyps where I would consider them in my hands unresectable, but somebody else might be able to. Right. Now, I had one lady in 5 years who said, "I don't want to go anywhere for that. Do I have any other options?" And I told her that I do recommend that it's completely removed. The only other option is partial colectomy. And I talked to her about it and essentially advised her against it, but she still said that's what she wanted, and that's what I did. And then she was very happy afterwards.
Was it a right, Hemi? Do you remember?
It was a right. So, it's not as bad as doing a sigmoid with a colorectal anastomosis. And so.
But, back before we did all these colonoscopies, it was a flex sig and a barium enema, and they'd see a filling defect in the cecum, and they'd take it out in surgery, and it was sometimes a tubulovillous adenoma.
Right.
And it was benign tissue, and they put themselves through that. I think with your well-informed patient, that's exactly what you should do. The patient got to be a part of the decision. She wanted you to do it, and right there in that hospital. So I respect that.
Good. So we talked about the sigmoid colon, and you're talking about pulling back and then stiffening the scope. I think about the colon. It has to stack up on the scope like sliding a sleeve off of your shirt or sliding your cuff up, right? So going in and out, for me, like kind of quickly with the lumen in view, not up against the wall, obviously, just a jiggle really gives me a lot of scope advancement. I don't know, that's a layman jiggle, I guess.
No, I think the jiggle technique, let's call it the layman jiggle. I think there's value to that. I'll often use the word accordion when I'm describing it to nursing students or something. We're just kind of gathering it up on here now. I had the scope into 80 centimeters, and we were maybe only this far in. And then we describe how we're pulling that back, and your sleeve analogy is really a good one. But that's exactly how I'd picture it. You're trying to gather that up. And then as you advance again, I think there's room for this abdominal pressure thing. So I call it the abdominal pressure maneuvers. And I've had speakers in the past poo-poo it and talk about if your surgeons are making you push on the abdomen, they're not doing it right. And I tell you what, I still think there's value in that. I think it needs to be gentle. I have one anesthetist that doesn't like it because he thinks it increased the aspiration risk. But in general, we still will do it. And I'll have whoever's in the room to assist. It's usually the nurse with a gentle fist or a palm, just almost. Once I gather back, I like to push the umbilicus, the belly button area, straight back. And to me, that just allows, it's a focal point for that question mark you talked about to kind of work around that pressure. That's another trick. When you have a big, deep splenic flexure, that can be a headache in a different way because all the pressure in the middle of the belly in the world doesn't change that. It just, that scope wants to go up into that splenic flexure. But again, the first goal is to just find a way to get that scope in. I'd say 1 in every 50 to 75 scopes will actually roll the patient onto their back. That's a trick late. I don't do that one very often, but every now and then I'm like, okay, let's try them on their back, and we'll roll them on their back and try a little more to find our way to the cecum.
Yep. Any other places to push pressure, or is it always, if you're doing pressure, at the belly button going straight back?
No, I think that's my go-to at the beginning. So we'll advance the scope, we'll come back, and I'll say, okay, let's put the pressure on. I'll say a soft hand straight back at the umbilicus, and we'll see if we can go. And then after that, I think it is a little bit more, honestly, I think it's a little more trial and error. We might compress the left lower quadrant, trying to hold the sigmoid down into the pelvic fossa. We might come high in the left upper quadrant, trying to splint that splenic flexure. But have you found a way to summarize better?
No, it's just, I think what's the point of the pressure? So the point is you start with a straight scope. You got to pull back before you do pressure, because what's happening is most of the time, 90+% of the time, your scope is looping in the sigmoid colon. And so you're trying to prevent it from re-looping as you push forward so that you can kind of push through that. So I think belly button makes sense. You push straight back and it kind of tampons it down there. I usually say left lower quadrant push towards the belly button. That's how I describe it to the person applying the pressure. I also use positioning the back all the time, but I always make sure I pull back first and I've got a straight scope, and it usually helps me around the splenic flexure. If I'm still in the rectum, obviously abdominal pressure is not going to help.
Right.
In the sigmoid colon, it's hit or miss, usually doesn't help. Usually I got to get my way through the sigmoid colon into the ascending colon before that becomes any benefit. But the other thing is sometimes you can loop in the transverse as well. And that pressure might be one where you're pushing epigastric and pushing up to try and bring a deep sigmoid colon transverse more into a more straight position. Yeah,
agreed.
Did I say sigmoid? I mean, transverse, make it
transverse.
straight.
I'm following you. Almost identical, except in my mind's eye, I would take, if I was working on the sigmoid, I would take the umbilicus and head down towards the left lower quadrant. You're pressing left lower quadrant up towards the umbilicus. And it's kind of a matter of how we're picturing this spatial anatomy, which is why I think I like that umbilical pressure. Just like you said, I think it just pushes everything down towards the left lower quadrant. The other one that's great is when the patient's relaxed and you haven't over-insufflated. So that's another key pearl, right? Don't use too much air too early. And if you have too much air, and then ride your suction button a little bit instead of your air insufflation button, and try and decompress things. And then I think the sleeve analogy works better when things are empty. So trying to keep the colon from being overinflated, I think, can be very helpful. But the point I wanted to make, the patient's well relaxed and sedated, they're not over insufflated, and you're pushing the scope. Sometimes the nurse will say, "Oh, I feel it." Now you have a clue.
Push right on that spot.
Right, that's the spot. Push that back down into the pelvis where it belongs.
Right.
And then we can advance the scope.
Yep. Very good. Have you ever heard of the scope guide?
I've used it once. The big hospital in our hometown here in Grand Rapids has the scope guide. And I have to admit, I found it helpful.
I love the scope guide. I think that if it's worth the investment to somebody that's going out kind of on their own in a small town early on. There's magnets in the scope. I don't exactly know how it works, but I don't know how my really my microwave works either, but I trust it. And what you see is a real-time picture in the corner of your screen that looks like what it would look like if you did fluoro. There's a little paddle that goes in front of the abdomen. This is I think it's an Olympus only product. There may be others for other different manufacturers, but you basically get a live view. And so you can see your loop. It makes me first off, it helped me to advance early on. And now it makes me so much faster because I pull back exactly how much I need so that I can see that I have a scrape scope, and I can do that so much faster and then quickly advance again.
Yeah. No, it's wonderful. The other thing I loved about the scope guide, Randy, was it validated what I thought I was seeing in my mind for the years before. When I could finally see that scope and the loops and things, I was like, oh, that's kind of how I pictured it. And you get to see it in real time, and it's a wonderful thing. Sounds like it's very time-saving for you, so that's a good addition.
Yep. Then going around the splenic flexure, do you have anything else to add about that? I would just say one thing that what I normally do is I go in with 0 on my stiffener. Yeah. And as soon as I get around the splenic flexure, I go boom to 3, like almost every time. I will sometimes change it based on what's going on. But once I've made it past the splenic flexure with a straight scope, that is over 90% of my looping. So I just want it to stay like that. And then I just kind of advance on through. I feel like that's made me faster as well. But
yeah, probably a good tip. No, I leave the scope soft until I need it. And so it's almost the same. If I'm around the splenic flexure and struggling, then I'll stiffen it up. But if it continues to advance for me and I know where I'm at and I'm looking at the appendix and the cecum, it's a lot of times I'm like, ooh, I'm still on soft. I'm still at 0 and I'm okay. And then I suppose like you, I always take a picture of the appendiceal opening. That's just part of my routine. I get a picture there. I've tried to intubate the ileum more and more lately. I had someone say they would start requiring that to validate position. I've never heard that truthified or validated.
I doubt that, but I have heard a description of how do you know someone's proficient at colonoscopy, and the answer was when they can intubate the terminal ileum at will.
Yeah, which is a great skill. And so I've been working towards that more often. Every now and then they want the biopsies at the terminal ileum, and it's nice to have the skill to get in there. But I would be humbled to say that I've intubated everyone, or to say that I could, because I've tried a few times in some that fortunately didn't need it, and it can be a trick.
Luckily, I'm persistent, and I almost always can get it, but it can be a lot of work. And then sometimes a little pressure there can actually reposition the colon sometimes too, sucking the air out. The last thing is going around the hepatic flexure. Do you have a tip on that one? Because I have a phrase.
Yeah, I want to hear it because no, I don't have a tip other than gentle persistence. But
okay, it's suck and pull, basically. So once you see the cecum, you need to suck all the air out that you can. Yeah. And usually pull back on the scope, and you will paradoxically fall down into the cecum very, very frequently. Right. And sometimes there's a Lehman jiggle associated with your sucking and pulling, and then you find yourself down in the cecum.
Yep, that's good. No, I think not calling it suck and pull, but I've fascinated many a student and I'll tell them, watch this. I'm going to pull the scope out, and you're going to watch it travel forward. And so that paradoxical motion that you talk about, that's a great skill also to have.
Also a half or a quarter clockwise turn. I'm doing that simultaneously.
Yeah. I think the twisting of the scope is the thing that's just time in the procedure room where you learn how valuable those quarter turns can be at certain positions.
Yeah. So some people, if you want to be fast, I would make sure that you're running the scope, both ends of the scope, I guess. Some people have nurses advance the scope for them. Again, like if you want to be fast at some point in your career, you don't have to be fast on day one, but it's worth it to learn how to do both.
No, I agree. That's what I do. And I think that's, sometimes the nurses are uncomfortable when you tell them advance or push. And so I think it's good that you do it on your own. I do that.
What else do we need to talk? This was, I would say, a very technical deep dive, and you're making me feel like I put so much effort into learning this skill. Maybe I shouldn't hate it quite so much, but
yeah, I've come to love it. I mean, the first 5 years in practice, my goal was to grow my practice enough that the junior guys would do all the scopes. And then I realized that, it's a pretty nice way to get home on time, and it's a scheduled procedure and it's somewhat predictable. And I've just turned it into my lifeblood and learned to not hate it so bad. So, yeah. The only thing I had a little asterisk is at our facilities I've implemented, and it might be required now, but the timeout at the end of the procedure.
Okay.
I think on colonoscopies is just super important. It's like, okay, what did we do? Okay, we did A through G, and then we go through what we called each of them. I take that note sheet with me to dictate the report. And so I think the timeout at the end is very important to make sure they have tissue in each jar and that we're all saying the same thing. But no, other than that, I think we can wrap it up, and I appreciate the deep dive. I haven't been able to talk with anybody about that for 20 years.
My pleasure. All right. And do you have any resources for somebody else that if they were going to do colonoscopy, on their own?
Yeah.
Maybe a mentor, or maybe I would love to have any textbook or website references.
Yeah, I don't. Other than the value of time in the procedure room, a patient instructor. I loved your 10-minute rule. What a great way to teach somebody without going crazy. Because when you're bringing a new partner in or teaching a family doc this skill, you need some guidelines, or you can go crazy. There's no way it's worth it for you to take the time out of your procedure list to do that. So I love that. I was going to, as far as resource recommendation, I was just going to emphasize the importance of collegiality and how rare a resource that is when you're a small town surgeon. And that's what brings us together as rural surgeons, is our isolation. And so we should all crave the collegiality. And so I was just going to plug our society and other chances to rub elbows next door to each other with real live rural surgeons doing the same thing we do, because that's when you can learn about the Lehman jiggle and things like that. But you need to sit together to do that. So any rural surgeon that's looking for a way to get that, just once a year out in Denver, the location might shift, but once a year we get this group together in January, and it's been very valuable. I save it because I don't have partners, right? I'm all by myself out here. I need partners and collegiality.
Yes, thank you very much. North American Rural Surgical Society in January, Martin Luther King Jr. weekend. Be there, be square.
Typically. Now, and my financial tip, let's do it really quick, is if you are a rural surgeon paid on an RVU basis, make sure you work into your contract some kind of a daily minimum, especially if you let other people schedule your day. So the classic for me is I take a day off to drive all the way to Big Fork, Minnesota for 7 colonoscopies. And I get there and we're only doing 4 because 3 canceled. Okay. So I would just say that as a rural surgeon doing these kind of things, and maybe it works even if you're a 1 hospital rural surgeon, you've got your whole day blocked out. If they're paying you RVU, think about making sure there's some way to have a daily minimum in your compensation.
Yep. That is something I'm doing everywhere now. So great tip. I love it. Thank you so much, Dr. Margo, for joining me. This has been nothing but gold about colonoscopy, and I just appreciate you taking the time to talk to us.
Okay. I hope you find several good minutes out of this time that you can put together to make a valuable podcast for your listeners.
Yep, I appreciate it. And I thank you too, listener, for joining us on this episode of The Rural American Surgeon. Don't forget to like, subscribe, share with your friends. Thank you for being here. I appreciate you. Keep up the good work, and we'll see you on the next episode.